Greetings and welcome to the NBMT Chronic Graft-versus-Host Disease webinar. At this time, all participants are in a listen-only mode. A question-and-answer session will follow the formal presentation. You may ask a question at any time by typing it into the Ask a Question feature on the left side of your screen. As a reminder, this conference is being recorded. It's now my pleasure to turn the call over to Jennifer Gillette. Please go ahead.
Thank you so much, Kevin, and for everything you do for nbmtLINK. We love working with you, and thank you everyone for joining us today for our Chronic Graft-versus-Host Disease webinar. We have some great presenters here today. We're really excited to bring you some more information about improving the quality of your life and doing this through occupational therapy, good nutrition, and then I'll also add some psychosocial strategies. So welcome. Just so everyone is aware today of our outline, we will first hear from Leora Ellen Comis, and she is a senior staff occupational therapist at the NIH. And then we'll hear from Sarah Henke, who is a clinical research dietitian from the NIH. And then, like I said, I'll also speak and give some tips, and we'll have a question session at the end. Just in case anyone is not familiar with the link, we're just going to take a couple minutes just to inform you about what we do. The National Bone Marrow Transplant link is dedicated to helping individuals and their families from diagnosis through survivorship. We work with hospitals, cancer centers, and other organizations to reinforce and complement medical care by providing resources, support, and education. We link you to experts across the country in all topics related to transplant and to others who have made it through the journey before you. Here is a picture of our executive director, Peggy Burkhardt, and myself on the right, and the staff social worker, Jennifer Gillette. And there's our phone number and our emails in case we can ever be of support to you. Some of the resources we provide to try to help people on their journey is, one, we have our Lunch and Learn programs. We have an award-winning Marrow Masters podcast series. We have multiple webinars like the one you are on today, and blogs from those who have been through the transplant process on all things related: disease-specific information, survivorship issues, coping, and symptom management. We also have a wonderful peer support mentor program where we can connect you with other patients, caregivers, and donors who have been through the process. We have our Second Birthdays Recognition program, our resource books, like the one you see on the right here, our survivorship book, as well as we have a new caregiver book out. And we also have emotional support and referrals and resources that we can provide. So if there's anything we can do to help, please reach out. And you also can go on our website or our Facebook page, and there is an abundance of information on there for you. A special thank you to our event sponsors today, Insight and Pharmacyclics and Janssen. We cannot do this work without you, so we certainly appreciate it. Just a quick little note regarding our medical disclosure for this program. What we're providing here for you today is some wonderful information that you can discuss with your medical provider, and the two of you can talk about if any of these tools might fit into your individualized medical plan. But we are by no way giving individual medical advice here today. So on to an introduction of our wonderful speakers. Leora Ellen Comis is our first speaker. She is a senior staff occupational therapist in the Occupational Therapy section of the NIH Clinical Center. She received a Bachelor of Science degree in Occupational Therapy from Indiana University, Purdue University at Indiana, and has a Master's in Public Health Administration from the City University of New York and Baruch College. She's a certified lymphedema therapist and has a board certification in physical rehabilitation. Her clinical research interests include the development of advanced standards of care with people with chronic, rare, and/or complex medical conditions, with a specialization in graft-versus-host disease, oncology, and lymphedema management. Currently, Leora serves an associate investigator on several protocols across various NIH institutes, including the National Cancer Institute, National Heart, Lung, and Blood, National Human Genome Research Institute, and the National Institute of Neurological Disorders and Stroke. She is a recipient of 4 Clinical Center Directors Awards, honored to be named as a fellow to the American Occupational Therapy Association, and has received several local, state, and national awards in recognition of her clinical skills. Leora has numerous peer-reviewed publications and national presentations associated with her research and clinical initiatives with chronic graft-versus-host disease, Turner syndrome, and premature ovarian insufficiency. So we are bringing the cream of the crop here for you today, as well as the cream of the crop, Sarah Henke. She is a clinical research dietitian at the NIH, where she works as part of the several transplant teams to assist patients in optimizing their nutrition status before, during, and after transplant. She completed her dietetic internship at the George Washington University Hospital with a special emphasis on critical care and nutrition support. Prior to working at the NIH, she worked at suburban hospitals covering a variety of services, but with a focus on nutrition, support, and critical care. And there is myself. I'm the staff social worker at the National Bone Marrow Transplant Link. I've practiced oncology social work for over 25 years. I received my master's degree from Wayne State University, and the majority of my career was managing the oncology social work programs at Ascension Health. As a direct care working manager, I've gotten the honor of supporting, educating, and learning from many patients over the years, and I love to use these lessons in my private practice as well as at the Link. And without further ado, we are introducing you to Leora to tell you all about how occupational therapy can assist you in your goals for wellness. Welcome, Leora.
Well, thank you for having me. I look forward to this presentation. I'm going to start with my next slide, which is I have no disclosures to report. And I'm going to talk a little bit about the objectives. I'm going to go back, sorry. A little bit about what I do as an occupational therapist within the GVHD team, and a little bit about some of the interventions we typically take for patients with GVHD. So what is occupational therapy? Occupational therapy basically addresses the daily activities people need and want to do when dealing with physical challenges that they may face associated with GVHD. We are unique in that we focus on function, and we may use tasks to restore a person's function, or maybe consider adaptations or home modifications to support engagement in desired activities. So what can you expect during an occupational therapy session? We'll start with an evaluation to find out what's important to you, what your needs are, what your goals are. Then we'll customize interventions that are specific to your concerns. And then we may do periodic evaluations to ensure that we're on target to meet those goals or make changes to the intervention plan as necessary. So I want to start with how we measure progress, because that's really important. And I want to highlight the fact that many of the OT measures are not GVHD specific. So you may have hand involvement, so we may use a hand evaluation, or if there's fatigue, we'll look at fatigue, or if there's sleep deficits, we'll do an evaluation focusing on sleep. We may incorporate both your reports through discussion and conversation, or maybe through observation. And we use these measures to document progress over time, and in my case, as well as for research purposes. So what do we focus on as occupational therapists? Well, there are two major categories. One is the physical abilities. How is your flexibility, your strength, your balance? Is there any swelling in your extremities? Do you have difficulties with coordination and manipulation secondary to GVHD of the skin? Does this impact your ability to get up and down from a chair or a toilet? And then that takes us to the functional abilities. How is fatigue impacting your everyday life? Do you get utterly exhausted just getting dressed? Or do you experience more fatigue with more exertional activities, such as running or walking for a prolonged period of time or standing in place? We'll look at roles and hobbies, what's important to you for your leisure. And sometimes you may experience brain fog, as I call it, or memory lapses, and that could impact ability to manage your pain medications or all your medications. And we'll inquire about vision. Do you have blurred vision? Because many times you'll have visual deficits associated with GVHD. And then last category is activities of daily living. To really focus on function. So ADLs, or activities of daily living, are broken down into two major categories. Basic activities of daily living, which focus on activities that are centered around your personal care, bathing, toileting, dressing. Whereas instrumental activities of daily living focus on activities within the home and the community, such as taking care of a pet, being able to pursue social or leisure time activities, be able to drive, very important ADL. So with GVHD, there are many potential bodily functions that could be affected. Most commonly, maybe neuromuscular, skeletal, which means there might be difficulties in strength or flexibility. It could impact range of motion. You have skin difficulties, whether you get tightness of the skin, may compromise your breathing and your respiratory function. And it may compromise your eyes, where you have difficulty with blurred vision or dry eyes. And cognitive functions, are you having memory lapses, concentration? Is there difficulties with opening your mouth for chewing or feeding? Do you have lack of saliva production or poor saliva production, impacting the ability to manipulate food and to swallow it? And then obviously sexual functioning, intimacy, the ability to be intimate with your partner. For purposes of today, I'm going to focus on the first four categories just because of time constraints. So what does the research tell us about intervention related to rehab medicine? Well, unfortunately, research is quite limited. There are not a lot of studies to draw substantial conclusions. However, there are some studies that have highlighted the relevancy and impact on function. So in a meta-analysis done by Muhammad et al., he looked at 3 studies, and they all found that with exercise, there was a moderately high benefit when it was guided by a therapist. In this case, it was by physical therapy. And there was only a moderate effect when it was guided by yourself without physical therapy intervention or guidance. In another meta-analysis, it was looking at 10 studies, and they found that there was a positive effect of exercise on strength, fatigue, and quality of life if started before transplant. However, if you were not very active prior to transplant, were not into exercise, and you started only after transplant, there was less of an effect. That does not mean you will not get better if you started exercise only after transplant. So the bottom line is the consensus criteria from NIH and other consortiums continue to recommend the importance of interdisciplinary collaboration, including rehab medicine providers, to help orchestrate a therapeutic program. So the first bodily function I'm going to talk about today is neuromuscular or skin complications. Very often you may see weakness. You may have decreased flexibility of your joints. Most notably, it usually occurs in the wrists and the elbows and hips and ankles. You may have swelling. You may have, because of the skin tightness, you may have open wounds or skin breakdown. So what do we do as occupational therapists for those conditions? The focus is on educating and starting on a individualized exercise program that includes very slow stretches. I want to emphasize the importance of slow, sustained stretch. So if you're in this case, on the upper right picture, this individual has restrictions in elbow extension. I will take the limb and extend it and hold it at the end range for a short period of time, starting at 5 seconds, and gradually build up to 30 seconds over time. So I want to emphasize the importance of it's slow. You don't want to be too vigorous or aggressive, because you're going to potentially cause trauma to the tissue. You can result in overstretching, and it can possibly cause a flare due to irritation or friction. Unfortunately, the literature is not consistent yet as to when is the optimal time to initiate exercises. But here at NIH, we start early, right after transplant, and we gradually increase the duration, intensity, and frequency over the course of time. Many people ask me, what about massage? I want to emphasize that you want to be with great caution when you do this, because there could be potential for injury that could lead to ulcers. So I would caution against deep friction massage, deep joint mobilization, and emphasize just slow, sustained stretch. We also, as occupational therapists, may fabricate or provide splints or orthotics, which help support the limb to help stretch the ligaments that are currently tight, and prevent further decline or degradation of the range of motion. So these are examples of different types of splints that I use in my practice with GVHD. The bottom right I don't use as much. This is a dynamic splint. This is fairly heavy, and you want to use it with caution because it can potentially compromise the integrity of your skin. So if you take anything from this portion of the presentation, the importance of continued stretch. Even when you feel like you've regained your full range of motion, you want to continue it on a regular and daily basis. Also associated with GVHD of the skin may be swelling. And we here in occupational therapy at NIH will maybe issue edema garments. I want to caution that we don't use garments too often when the skin is very thin and fragile, because there is a high risk for breakdown. So my go-to is on the upper right, which is an example of a Velcro inelastic compression wrap. It's easier to apply. There's no friction when you're pulling it on or pulling it off. And it does do the same benefit of reducing some of the edema. There's also bandages, and there are electric pumps. The last two are very individualized to the patient's needs. So I just want to emphasize that this is not something you go out to Walmart and get, or Target, and get compression garments. You really want to get fitted and measured. We want to select the right compression gradient that would suit your needs after looking at the skin integrity and the degree of and the quality of that edema. All right, Kevin, can you advance the next slide? I'm having difficulty. Okay, Phillips. Sorry, guys. So we're looking at the quality of the skin. Hold on a second, I'm sorry. And many of my patients come in wearing tightly fitting clothing or brassieres that have underwire. So I want to caution that you want to use loose fitting clothing that does not compromise the potential for breakdown. And in the summer, you may want to use clothing that has UV protection to minimize the risk of sunburns, because many of the medications you may be on have photosensitivity, and you're more at a risk for burns from the sun. And nowadays, there are so many clothing lines that have adaptations that don't look medicinal. They don't look in your face. They have zippers on the side of the trousers, or they have Velcro instead of zippers for the fly, to make it easier for you to readily don and doff your trousers. So we may, as occupational therapists, make recommendations on clothing options to consider. The third category of bodily functions that may be impacted by GVHD is your breathing. You may be more at risk for infections, fluid that builds up around your lungs, and compromising your ability to breathe, shortness of breath, reduced strength around your chest wall cavities, which can lead to postural abnormalities. And in the next slide, you'll see this is a gentleman with GVHD, and the skin tightness has compromised his posture. His shoulders are rounded. So what do we do as occupational therapists? We'll emphasize the importance of proper body mechanics, maybe how we can alter or modify the chair to enhance extension or elongation of the chest wall so it fully opens up. We'll emphasize the importance of pursed breathing, which means you're taking a breath in through your nose and out through your mouth. Many times during an activity that is fairly effortful, we'll hold our breath, which is not what we should be doing. And as an OT, I focus on teaching, I call the 3 Ps, which means I emphasize the importance of prioritizing what's important. What do you want to do that day? Okay, I want to do X, Y, Z. I want to go shopping, and then I want to put the groceries away. And I'll plan out, okay, am I going to be able to go through the whole grocery store? Maybe just go to the perishables today. And then I want to pace myself. I may need to take a scooter within the grocery store, or just stop and rest, or use a trolley cart to carry and transport my groceries to the car. So it's kind of rethinking how I'm going to do things to save my energy. I like to use the analogy of bank. I'm putting money in the bank. If you continue to take out energy from the bank, in this case, energy instead of money, we're not having any money left over or energy left over for the more important activities of daily life and the things we like to do. So I emphasize the importance of pacing. We may explore home modifications or the use of adaptive equipment to enhance your ability to not strain when bending. So long-handled dressing aids, so you don't have to stay and struggle putting on your shoes, or sock aids. If getting up from a toilet is too difficult because it's too low, maybe making some bathroom safety equipment recommendations like a VersaFrame. And so why do we use adaptive equipment? Well, the adaptive equipment first must meet your needs. It must fit your roles and what's important to you in your life to enhance your safety and be commensurate with the financial resources, so we're not expending on buying things that are unnecessary. So I really take into consideration what's important to you, and maybe adaptive equipment can help enhance that autonomy, reduce the strain on your caregivers or family members, and achieve that sense of independence and reduce the pain associated potentially with bending or reaching or lifting. So these are just examples of some adaptive equipment within the self-care domain, for managing buttons to bathroom safety equipment. This is an example of a VersaFrame, that's the middle photo on the upper photo. Reachers, which is the bottom right, which helps to pull on a shirt, or in this case, a suit, to get it over the shoulders. Long-handled combs or brushes, and on the bottom left was let me go back, sorry guys. Example of sock aids. And then in the arena or domain of instrumental activities of daily living, there are many devices out there that are very helpful to reduce the effort. For example, on the upper right is an example of a handy bar, so that you don't have to hold on to the car door, but you have something to prop against to help you get in or out of a car. loop scissors, upper left, so you don't have to expend energy if you're a seamstress, constantly opening up. Its spring action opens, and all you have to focus on is closing. The bottom left photo is an example of a jar popper. That just helps make it easier to open up a jar or a bottle. I use furniture risers a lot in my practice, so recommend them, because sometimes the sofas or the couches are so low, it's a real effort to get up. So I would emphasize the relevancy of potentially furniture risers in your home, or just a simple adaptation is put several pieces of foam or pillows to increase the height. And then the last photo on the bottom right is an example of a key holder. The last bodily function I'm going to talk about today is vision. Many times with GVHD, you may have dry eyes, photosensitivity, but it impacts greatly your ability to read or to spend time at the computer. So what would I recommend as an occupational therapist? I may consider employing humidifiers or air filters within your home or office. I like ebooks over reading of a book, because that you don't have the challenges of fluorescent lighting, but the ebooks have backlighting, so it reduces the strain on your eyes. I also teach what I call the 20-20-20 rule, which means when you're at the computer or when you're working on a notepad or ebook, that every 20 minutes you look at an object at least 20 feet away for at least 20 seconds. So you're giving your eyes a break. And sometimes we get so much into what we're doing on the computer that we forget to take those breaks for our eyes. I also may recommend moisture chamber glasses. This is an example of one. So it basically has an eye cup around the inside of the rim that reduces the evaporation and tears and keeps your eyes from getting too blurry. We also may consider modifications to the computer. A very simple and easy fix is enhancing the font size, changing the contrast from black font on white background, which can be very glaring, to maybe green or black background. Use of an anti-glare screen or filter, very low-tech, nominal cost, goes right over the monitor, reduce the glare. Just the way you put your computer, if you position your computer away from the window so your back is to the window, so you're not having that direct glare. And how far away is the monitor? Or how far away are you putting the book? Maybe I may use a book holder, so I'm not having the strain of holding the book, and I can position it in a proper angle. So in summary, what do we focus on? We're part of the team. We don't work in a vacuum. We are part of a team. We use occupational therapy to maximize your function so that you can engage in activities that are important to you. So in essence, I want you to live your life to its fullest with autonomy and sense of competency. This is a photo of a former patient of mine who has GVHD, and he was able to return to his passion of fishing. So I want to have a big shout out to the NIH GVHD team, to my colleagues, and most of all, to my patients here with GVHD. I've learned so much from you, and I hope to learn and continue to learn through today's presentation. Thank you, and I'm going to pass it on. And oh, by the way, here's my contact details should you need to reach out to me. Thank you very much for inviting me.
Thank you so much for being here, Leora. That was a wonderful presentation, and I know I myself have learned some great things here. Next, we have Sarah. Thank you for joining us today, Sarah.
Thank you so much for having me. Start with my slides. So I'm going to talk a little bit more about building off of Leora about the ancillary services surrounding GVHD management by going into a little bit more with the nutrition management of graft-versus-host disease. So as we're all pretty familiar, graft-versus-host disease is a common complication after stem cell transplant, and we know that there's two different types, acute GVHD and chronic GVHD, both which can severely impact a patient's nutrition status. Just quickly, acute GVHD, which can occur anywhere from 3 months to a year after stem cell transplant and can impact a large number of tissues, including the skin, the GI tract, and the liver. And then chronic GVHD, which we're focusing on today, occurs anywhere from 3 months to a year after hematopoietic stem cell transplant. And as with acute GVHD, can cause a number of tissues, but with chronic GVHD, it's a much wider range of tissues that are impacted, with the mouth, the skin, the GI tract, lungs, liver, muscles, joints, eyes, and any number of other tissues involved. The tissues that are impacted, particularly with the mouth, can cause dryness, mucositis, food sensitivities. With the GI tract specifically, patients can experience diarrhea, malabsorption, electrolyte disturbances, and ultimately this can lead to malnutrition, which we are constantly working to prevent. So gastrointestinal GVHD, like I just mentioned, can impact anywhere along this GI tract, and any inflammation in any area here can lead to malabsorption, decreased intake, dehydration, weight loss, severe electrolyte disturbances. And it's our goal throughout working with someone with GVHD, the main nutrition goals are to minimize gastrointestinal dysfunction, control symptoms, and then provide adequate nutrition support for that patient. So here you can see the standard nutrition interventions that are common across pretty much any disease state. As a dietitian, we try to work with diet modification, enteral nutrition or tube feeding, and then parenteral nutrition. These are all the tools available at our disposal. Today I plan to talk primarily about diet modification, but I do want to mention that enteral nutrition or tube feeding is often actually not recommended in patients with severe GVHD, and TPN may end up being recommended in cases of severe GVHD in which the patient has severe dehydration, severe diarrhea, and we're worried about dehydration or malabsorption, and if the patient is being recommended for bowel rest for a prolonged period of time, or a patient who shows up presents with malnutrition. So these are the options we have to work with, but primarily we like to start with diet modification to see if this works, because it's the most natural way to emulate the body's normal biological functions. So diet modification is implemented when oral intake is recommended, and bowel rest may preclude this from happening. So a patient would be made NPO or nothing by mouth to promote bowel rest until diarrhea output is within goal range. This is usually less than 500 mils per day. And when this is achieved, we can start with diet progression. Patients are typically guided through a stepwise diet progression, usually beginning with an isotonic clear liquid diet, and then moving on towards a more regular diet. We call it the GVHD progressive diet here at NIH. And we move on more towards that regular diet as the gut function improves and patients are able to tolerate a wider variety of food items. So the isotonic clear liquid diet is comprised of fluids that are the same concentration as body fluids and limited in concentrated sugar in order to prevent excess fluid from being pulled into the intestine and worsening diarrhea. So there you can see a list of foods that are on at least on our isotonic clear liquid diet here at NIH. This is typically broth, so beef, chicken, vegetable broth, Gatorade, diluted juices, Jello, decaf tea, and in some cases we permit water and hard candies. Hard candies, even though they have a high concentration of sugar, can help with mouth comfort, and so we do allow them in certain limited amounts. So after several days of symptom stability and demonstrated tolerance of the clear liquid diet, the patient can progress to the step 2 GVHD diet, which is a low lactose, low fiber, low fat, and low acidity diet. When the intestines are damaged, lactose becomes difficult to digest. Low fiber here specifically refers to insoluble fiber. So foods such as oatmeal, applesauce, and bananas, which are all sources of soluble fiber, are acceptable. Insoluble fiber can exacerbate diarrhea symptoms because its goal is to go through the GI tract and kind of scratch along the intestine to help promote the bowel motility, whereas soluble fiber forms more of like a gel once it's in the GI tract and can slow down stool output. So patients who are having issues with diarrhea, soluble fiber is usually a good option. So we also choose low-fat foods because they're generally easier to digest than high-fat foods, and they're also less likely to cause nausea. They also like fiber. The soluble fiber, lower-fat foods help with diarrhea management. Finally, we try to restrict acid foods because they can be painful on the intestines and also the mouth if the patient is experiencing mouth sores. So we often recommend avoiding foods such as tomato sauce, pineapple, spicy foods. In addition, I also want to mention that it's important to keep in mind, too, at this stage that many patients will be neutropenic during this period. Therefore, any food that's eaten during this time should be prepared with adherence to immunosuppressed food safety guidelines. So here is an example of what the progressive diet or step 2 of the GVHD diet would look like, with on the left being the foods that we would start introducing, such as applesauce, ripe bananas, plain white bread, plain pasta, tender, very well-cooked vegetables such as carrots, and then well-cooked lean meats such as eggs and such as cod, chicken breast, also including tofu, anything like that that's soft and easy to digest. And at this point, really avoiding anything that might irritate the gut lining, so fried foods, full-fat dairy, whole grains, raw fresh vegetables, anything with skins is really something we would just avoid at this stage. So once you tolerate foods in the step 2, we'll slowly start adding back some of those foods that we had not permitted in the stage 2 diet. So, this could look like adding back in whole wheat bread or brown rice or a higher fat protein. And when we're looking for whether or not the patient is tolerating the food, we're looking for indications of abdominal pain, increased diarrhea, persistent nausea and vomiting. And this indicates that if the patient's having any of these symptoms, that they are not tolerating this advancement and may need to regress to the prior step. If the patient is experiencing anything severe, more severe, such as intestinal bleeding or severe impairment, the diet progression should be stopped, and the patient should speak to their provider about further treatment options. So there's often side effects that are correlated with GVHD. We've mentioned diarrhea a lot. And so when patients are experiencing diarrhea and we're on a diet, to modify the diet that they're normally on, we also recommend drinking plenty of fluids and staying hydrated. A lot of fluid is lost through diarrhea, especially uncontrolled high output diarrhea. So we want to make sure that we're replacing any fluid lost by drinking enough fluid, or even using Gatorade or Pedialyte to make sure electrolytes are also provided. We also try to encourage patients to eat small, frequent meals throughout the day, and avoiding large meals and avoiding the standard 3 large meals. This would look like breakfast, snack, lunch, snack, dinner, snack, just to slow down the introduction of food and give it time to be absorbed by the GI tract. Again, avoiding insoluble fiber-containing foods and adding soluble fiber-containing foods. Again, this is the applesauce, bananas, white rice, white toast, and then avoiding greasy, fatty, or fried foods until the diarrhea starts to resolve. Other symptoms, the nausea and the vomiting, managing this looks like drinking small amounts of liquids throughout the day. As with diarrhea, there's a lot of fluid lost if there's excess vomiting, so making sure to replace fluids that are lost, and avoiding drinking large amounts of liquids at a time. Small sips frequently throughout the day is generally the recommendation. And again, small, frequent meals can help prevent irritation of the stomach and the feeling of fullness. For some people, too, they develop sensitivities to cold or room temperature foods, or conversely, they'll develop irritation with hot foods. So finding out which temperature seems to work best. This could be done through trial and error. And then avoiding foods with strong odors. So this could look like, not putting lids on foods that have large, potent smells. So when you take the lid off, that smell can be even more concentrated. And this can also be managed with eating room temperature foods and using plastic silverware, because the metal silverware can impart flavor that maybe you weren't looking for, which can contribute to nausea as well. And then lastly, there's mouth sores is also a very common side effect. And so some things that we recommend are using ice chips or popsicles to numb the mouth prior to eating, especially if you have, irritation in your mouth. This can be really helpful in numbing and making it easier for you to tolerate a wider variety of foods. We also recommend cooking foods until they are soft and tender, and avoiding anything that's really crunchy and could scratch the lining of your mouth. So chips, crunchy vegetables, any nuts that might scrape. So just going for soft foods that make it easy to chew and swallow without too much effort. We can also mix foods with gravy or sauces to make them easier to chew and swallow. This also has the added benefit of an increase in calories, since gravy and sauces can be pretty high fat and often are made with butter. So if you've progressed past the stage of, GVHD2, where you're adding in more fatty foods, gravy and sauces can be an excellent way to increase your calorie intake, as well as making the food that you're trying to eat more palatable. We also recommend using a straw often to direct fluids away from sores. So especially if you have sores on your mouth or in the side of your cheek or on your tongue, a straw can direct the fluid past that sore and make it easier for you to tolerate that liquid. And then just in general, avoiding acidic foods. They even if you can get them past your mouth, they might irritate your stomach lining or your esophageal lining, or further in your gastrointestinal tract, and just generally is a good idea to avoid if you're having any kind of symptoms. So overall, diet modification is an important way to control unpleasant side effects of GVHD. And we want to emphasize protein intake and hydration as much as possible, especially with patients who are at high risk of malnutrition. And the thing to remember, and that we tell a lot of people, remind people a lot, is that you will eventually be able to enjoy most foods again. This is not the time to be introducing your favorite foods and trying to find a way to eat your favorite foods. This is the time to make sure that you're maximizing protein and hydration, and once the GVHD is resolved, you'll be able to enjoy normal foods again. And the other thing to remember too is that it's important to communicate with your team. If your symptoms don't get better, there's a lot that can be done, and it's important to make sure that you can get the help that you need when you need it. So with that, I think we're going to open up to questions. Is that right?
Actually, I'm going to do my presentation next, and then we're going to open up the floor to everyone. And Kevin will instruct everyone if you haven't figured out at the bottom of the screen how to ask your questions. But we'll be getting to that shortly. But first, we're going to talk about approaches for thriving with chronic graft versus host disease. Time and time again, we hear, I thought survivorship would be different than this. I know someone had showed me a cartoon the other day of what you feel like on the outside after cancer, saying, I beat it, yay. But then on the inside, all the questions of, I thought I was going to be better. I thought I was going to look different. I thought my hair was going to look different. I thought my body was going to respond differently. There's a lot of expectations that aren't met when you're dealing with GVHD. And unfortunately, GVHD is not rare. Up to 70% of transplant recipients develop acute GVHD, which crops up within the first few months of treatment. And then 40% get chronic graft versus host disease, the form that appears more than 100 days post-transplant. So as the name implies, the chronic condition can last for years or even a lifetime, and its symptoms range from mildly annoying to sometimes very disabling. It can be frustrating for patients who find themselves cured of this primary disease, but now are trading it for another chronic illness. And then we have patients with chronic GVHD who, in 3 to 5 years, it kind of runs its course and they're doing much better. But approximately 15% require treatment for a longer period of time, and in rare cases, they may even need lifelong immunosuppressive drugs. However, I also come to bring you hope today. There is hope. There are gains being made in the development of new medications and new treatments. One is even being given proactively to help lessen or prevent symptoms, especially with those that have had transplant where there wasn't a great match. That new drug is called a betacept, I believe is how you phrase it or say it. But there's other drugs that are coming out too, because GVHD, as the two speakers before me had spoken of, talking to your providers, there's systemic medications that can be given, there's topical, there's all kinds of devices and different things to try to make it easier to live with those symptoms. But a good guide for you is, one, talking to your provider, but there's also something called the National Comprehensive Cancer Network. And for every cancer that exists in America, this is the guide for how they handle those cancers, because everything your doctor does is based on research. And the latest guidelines for these diseases are given step-by-step approaches. So if you go to the National Comprehensive Cancer Network, You can look at what the approaches are with graft versus host disease, and it serves as a piece of information to help you and your doctor have good discussions on where to go next. Education is key in coping with graft versus host disease. You know, there are so many wonderful organizations out there that can bring you the latest research and what's happening. Like tomorrow, for example, the Meredith Cowden Foundation is having a virtual symposium with some of the latest on breaking treatments for graft versus host disease. When we send you the survey at the end of this, I will send you a link that if you're interested in registering for that, that is one that you could do very soon. But you also can keep an eye out for the Leukemia and Lymphoma Society, obviously National Bone Marrow Transplant Link. We have all kinds of great programs, DKMS, BMT InfoNet, Be the Match, and as I stated earlier, the National Comprehensive Cancer Network. So keeping yourself educated can, again, create great conversation for you and your doctor. Oops, sorry. Let's advance here. And then also learning from your fellow survivors. There is no one size that fits all, but the people that have walked this before you have learned some great tips to pass on. And I'm going to share some of those with you today. One is I want to show you this great picture here on this slide. This is Juanita. Juanita's on our board of directors, and she is 25 years post her bone marrow transplant. She is vibrant, she's active in her community, but she has had a tough story, like I'm sure most of you on this call have to share. But here she is 25 years later, and she's doing well. But it starts with having a realistic view of what coping is at each stage. Because just like it takes time for your body to heal from all of this, it also takes time for your emotions and your spirit to heal from it. And this is something that can't be seen. People might have unrealistic expectations of you thinking, oh, you know, I finished cancer treatment, I finished my bone marrow transplant. I had one lady even call me who she was 2 months after her bone marrow transplant, and she felt so guilty that she wasn't working yet. And she didn't quite understand. I don't know where that message wasn't given to her that expecting yourself to be back at work 2 months after a transplant is not a realistic expectation. And so we talk through that on what looks normal at different stages. Also, be very careful on saying, well, I shouldn't be this, or I shouldn't be so lazy, or I shouldn't be, this is just where you are right now. So don't judge where you're at. It's learning how to work with what you have. You're going to try to get your body back, but it takes time. And then also, I want you to remember that when you have survived a bone marrow transplant, it is like going through a personal earthquake, which has required an increased tolerance for the unknown as you walk with exhaustion, consistent pressure, grief, loss of identity, relationship changes, loss of control, and chronic graft versus host disease can certainly cause distressing symptoms that can make you feel discouraged. So to find out how to live the best version of you, it's making the best of what your body can do at each stage. And then it's also finding ways to cope, minimize emotional distress, finding ways to reconnect with the world around you, and establishing a renewed sense of meaning and purpose in your life. And some of this is going to be through trial and error. Like I know some patients have told us, well, I really pushed myself because I wanted to see where my limit was, but it threw me back for 3 days. So I know my limit is not quite where I tried the other day. And so it's really just a little trial and error and just being really patient with yourself. It's walking in balance with persistence, patience, hope, and acceptance. So again, setting realistic expectations. What is your norm? And then trying to reclaim areas of importance in your life while allowing for flexibility and creativity. Understand that everyone that loves you walks this journey with you, and you may cope differently, but work together as a team to support each other. Know when to ask for help and learn to say no. So here is another wonderful survivor. She's a gem at the National Bone Marrow Transplant Link. This is Meredith. She's 20 years out from her transplant. And what she recommends is discover what time of day your body's at its peak and try to schedule what you need to do during these times. So, for example, let's say from 9 to 11 you seem a little more spunky than the rest of the day. That's probably a good time to schedule your appointments. Allow yourself to have breaks. Maybe before you could do a full day of working, but when you first start back to work, that's probably not realistic. And then prioritize. I know Meredith had a great story about spoons, and she said, imagine you have like 20 spoons for energy for your day. And when you say yes to one thing and you put one of your spoons into it, then you have to realize you only have so many spoons to give away. So you might be saying no to something else. And so it's really important to say, okay, well, here's the most important thing I want to do today. Maybe I just have enough energy to read a book to my child or make enough energy to make a meal, but more than that is too much. And so whatever is a priority is where you have to put your spoons. Also, break bigger tasks into smaller tasks and become your own author in life. You know, a lot of things are perspective. It's a matter of we can't change what happens to us, but we can change how we choose to deal with it. We can change maybe getting better support, better resources, or choosing. I saw something online the other day on choosing your hard. Sometimes we're going to pick, we don't have the greatest choice of what we're picking. Both are hard, but it's a matter of which ones are a goal. So it might be hard to get out of bed, but it also might be hard and maybe you're more stiff staying in bed. So which one puts you closer to reaching your goal? And then discover what brings you meaning, joy, and hope. And I want to remind you that when you're setting your goals, keep in mind much can change over this journey, like Meredith talking about where she started from to where she went. I'm thinking of an interview I did with a man named Tom a little while back, and he shared after his transplant how he had actually fallen asleep in the bathtub. 4 years later, he was running marathons, but there was a lot of steps in between. And so, like Meredith, like Tom, just taking those little steps one day at a time to get closer to your goal, but not being unrealistic at the pace on which you can do that. And these are tips from David, another gem of the link. He's a 15-year survivor. He recommends finding ways to stimulate your brain. He found learning a language or doing crosswords were helpful to him. He also tried to look for positives, including finding ways to be social, even on the transplant floor. David is a firm believer in exercise, and as much as your body might not feel like doing it, doing a little at a time and gradually adding more can certainly increase your energy level. David's also a high promoter of having quality foods instead of junk food. But again, remembering which stage you are in. I know we just had a lunch and learn last week, and she was saying in the beginning, the only thing her body could tolerate, I believe, was Chipotle and Pizza Hut, and that was the only thing it could keep down. So that is what she ate for a little while. But certainly those high-quality foods, remember your foods are medicine. When able, David recommends getting involved. He found it very helpful to be able to give back to others, and that just really helped him with his spirit and sense of purpose. And then also accepting life will never be the same. It's different, but you increase the quality of your life. David was someone who was very successful in corporate America, and after his transplant, he chose to live a life that maybe represented his values better after cancer. He was a stay-at-home dad for a while, and that really helped with his relationship with his son. He also now works with a program in California where he makes high-quality, nutritious food for cancer patients, and that really helps with his sense of purpose, as well as he's wonderful with pottery and ceramics. David says also, fatigue is no joke. Get the rest you require, and it helps you get more done in the long run. He also recommends considering counseling because sometimes we all just need it, and it can just help you unravel all the thoughts going through your head. And it's also a safe place where you can say anything and not be judged or worrying about hurting anyone's feelings. David also found it helpful talking to a peer mentor at nbmtLINK, someone who's been through it successfully before. And for the record, David is one of our peer mentors. If anyone would ever like to talk to him, he is just an inspiring person to talk to. And here's tips from Jen. Jen Barish, she is 11 years out from her transplant and has volunteered and educated for us at the Link and just has a lovely family. Jen recommends keeping a list of the gains you make so you have something to reference when you feel discouraged. Imagine, for example, if you're a parent, and people come up to you and say, oh, your son's grown. You might not see it because you see them every day, whereas the people on the outside coming in do. And it's the same thing with your progress with GVHD. You might not realize that you're making gains. And so if you do something like the first time you walk down to get the mail or the first time you do something at home, make a little note of it. So when you look back, you can go, wow, over the last 6 months, I really have made a lot of gains. Jen also learned how to adapt with the changes she noticed with herself. She worked in a high-rise building, and one of the things she found is before her transplant and her cancer journey, she never had an issue going up the elevator in that building. But after, she found that she would be all stuffy and everything due to the GVHD. And so she talked with her doctor about getting some medications to help her with that. She also shared that walking around the office for an hour, resting her eyes from the computer, those were important things in helping her to return to work, to make some modifications. And she also said, make sure you're strong enough before you return back to work. Don't push yourself too quickly. Make sure you really feel ready. She also recommended a video we have. It's an older one, so you might see some older looking video, but it is a really well done piece by the person who started the Link. It's called The New Normal, and if you go on YouTube, there's an 8-part series with it, and it really walks you through what healing looks like after a transplant. Jen also shares how important it was to see this recovery as a marathon and not a sprint. And then these are tips from Lou. Lou is an Energizer bunny, fighter in every sense of the word. He is a 9-year transplant survivor, 2 of them, as a matter of fact, and a heart attack. He survived the towers, and he is also one of our peer mentors. He viewed his transplant as a recall to life. He and his wife were a team that had an attitude of whatever it takes to fight this, we're going to do it together. He had a strong support team, and he chose a project to distract himself. That is a great tool when it comes to the emotional aspects, especially anxiety, calming activities, distracting activities, physical ways to vent, like exercise, and emotional ways to vent are an important tool in dealing with anxiety and other big emotions. His wife and he also enjoy walking together, and one of the things that motivates him is an app called charitymiles.org. Large corporations will make donations to the charities that you choose off that site based on the miles you walk. So if you know that getting that walk in tonight is going to help a charity that you're passionate about, you are more likely to put those shoes on. But Lou is just a delight. And again, a peer mentor if anyone wants to talk to him. And then we have tips from Rhonda. Rhonda, she inspires me in so many ways. Rhonda, as a runner, she shared that she sees the transplant journey like a marathon and not a sprint. She framed her experience to be a mile she had to frame her brain to run 26 times, instead of looking at the whole marathon, which is 26 miles at once. Every day she asked herself, what can I do to make myself physically stronger, mentally stronger, more positive, spiritually stronger, and socially stronger? She believes that 80% of this fight is psychological and envisioning your goal. Like one of the things she did after her transplant, she was a young woman that was just married and found out she had cancer and had to go through all this. She noticed that if she sat in a chair a few minutes right after transplant, instead of the bed, she felt a little stronger. So she would push herself to sit in that chair at longer periods. And that helped her every day as she just tried to push a little bit past her limit. She also recommends being informed of medications, symptoms, and concerns. And keep your eyes on the prize. It's a second chance at life. Change negative mindsets, and remember, you are not a burden, you are a blessing. Don't do that negative self-talk. And she also says, learn to ask questions and speak up for yourself. It's hard to keep up with others socially. However, everyone needs support through this. She chose to blog, and that was a safe way, especially for all of you listening that are going through COVID as you're going through this journey. Blogging is a way where people can respond to you, you can keep people informed, and it also can be an emotional outlet. She had someone that was her liaison to also control her social agenda. They arranged visits when she was up to it, but also informed others when she was not up to it. It helps to have someone also helping with things like finances and assisting with negotiating payments and things, because that might just not be a spoon you can give that day. Spiritually, she found that she had to figure out that what this was in her life. What is my connection? And then this went beyond a belief of doctrine. It involved a belief that I can and I will continue. And she said to be at peace with your choices. There is no fruit from sitting there and second-guessing everything you woulda, coulda, shoulda done in the past. You deal with what's happening now, and you do the best you can in the moment and accept whatever that is. She shared several losses, and she took time to review options every time she faced a loss. You can't always choose what happens to you, but you can choose how to handle it. Fighting for your life takes enormous courage, and you need to will yourself out of bed every single day. We also recommend communicating with your healthcare team. Develop a system to stay organized because, as you know, these doctors have to unfortunately move around quite fast, so every minute counts. Communicate clearly and honestly with your providers, and keep a running list of symptoms and changes that you can share in those moments. Be a strong advocate for yourself. Have a medical coordinator for your care. Copy other healthcare providers on emails, and use the whole healthcare team. One of my favorite people are nurses, because those doctors are so busy, and the nurses are busy too, but usually if you can find one person that you can really contact in the office if something comes up that can communicate with the team and get back to you, that can really help. And then consider attending conferences. Most importantly, don't give up. So the key with coping today is you can't stop what happens to you. You can't stop those waves, but you can learn to surf. And this is best done with education, support, coping tips, and your faith, whatever that is for you. So now we are going to open the floor for questions. So Kevin, could you please explain to everyone, just in case they have not figured out at the bottom of the screen, how to
Absolutely. If you'd like to ask a question at this time, please type it into the Ask a Question feature on the left side of your screen. Once again, if you'd like to ask a question at this time, please type it into the Ask a Question feature on the left side of your screen. Back over to you, Jennifer.
Oh, thank you, Kevin. I'm going to start with one for Leora. Leora, we have one here from a professional that asks, how do we differentiate our role as an OT in a team that includes PTs, and I'm sorry, abbreviation in healthcare happens all the time. So how do we differentiate our role as an occupational therapist in a team that includes physical therapists also in the bone marrow transplant program?
That's an excellent question, and a question I get quite frequently. I'd like to think of us as a member of a team. So it's critical that you have both physical therapy and occupational therapy on that team. Physical therapists will typically focus on mobility and how you're able to get to your destination. I like to think of it, OT, as taking it a bit further than once they get to their destination, whether it's the bathroom or the kitchen. Can they do what they need to do in that room? Can they reach their groceries? Can they get their pots and pans out? Can they stand long enough to do a meal? So both clinicians are critical. Occupational therapists historically have been specialists more in the upper extremities and in the fabrication of splints and orthotics. We also tend to focus a lot on adaptation rather than just purely exercise. So both disciplines critical in that team of providers. I hope that answers the question. If not, feel free to elaborate in your question.
Great. Thank you, Leora. This one's for you, Sarah. I'm 17 months out of my allo transplant. I lost a lot of weight, and I'm trying hard to gain weight. I eat a lot of protein, but when I try to slowly add fat, I will vomit, and I have worsened diarrhea. What should I do?
So what I generally recommend is when trying to reintroduce fat, go slow and stick with one kind of food until you see that you can demonstrate tolerance. And typically that can look like starting with something that's low fat but still has fat in it. So thinking of fish, something like cod that's a low fat fish versus something that's like salmon that's a higher fat fish. So starting that and seeing if you can tolerate that and then slowly progressing. You may find, however, that even with the lower fat foods, if you're unable to tolerate those, it may be a sign of like a pancreatic insufficiency, especially when we do some pretty major damage to our GI tract. We may not be producing the enzymes that we actually need in order to digest fat or protein effectively. So this might mean having a conversation with your medical team about whether or not you need to go ahead and add pancreatic enzymes in, which can help digest the fat and make it easier for you to absorb it. Because it just could mean reteaching your GI tract what it means to digest fat and absorb fat. And the other things recommended are to avoid, if you're having a hard time adding fat and you're vomiting, avoid having it with fluids. So I would separate fluids from solids. Eat your meal with your solids and then wait about 30 minutes before following up with liquids, and definitely avoiding drinking large amounts of liquids at the same time if you're finding that that's the problem. And you can also try to incorporate it with something that that you can easily digest. So if you find that you can tolerate like white rice really well or pasta really well, try adding olive oil to the pasta and seeing if that's something that works for you and just makes it a little bit easier to digest once you dilute it and give your body a little bit more something it knows how to tolerate and knows how to digest, and then introducing the new food and seeing if it can figure out how to adapt to that.
Thank you. There's also one underneath that asks about, is it safe to eat canned beets with blood cancer, particularly myelodysplastic syndrome?
Yeah, it's totally fine to eat canned beets with blood cancer. I would make sure that you're checking for making sure that the can itself is, doesn't display any signs of bulging or denting. The concern there being that there would be any kind of like botulism or foodborne illness that's waiting inside that can that hasn't been appropriately treated. But in general, we recommend, as much, fruits and vegetables as tolerated, and canned beets can certainly be a good option there.
Great, thank you. And Leora, I see one here for you. Could you describe what could possibly trigger or make GVHD work or reemerge? Do you have any
Very
thoughts
good.
on that?
Yeah, that's a very good question. There could be several. It could be from overexertion, where you just try to do too much and you're taxing your organs, particularly your lungs. It could be over-exercising. It could be the environment where you're in a highly, where there's a lot of infections that could make you more vulnerable. We do know that for very common GVHD symptoms, that over massage or deep tissue massage can trigger a flare of the GVHD. So I would really suggest that you speak to your provider to get a little bit of guidance as what you can do to minimize these risks to avoid a trigger.
Thank you so much. I know we have another question on here about will GVHD symptoms eventually go away? As was stated earlier in the program, this is a very individual journey, and it's important that you and your provider are working hand in hand. And there's also specialists that you can see if you're having difficulty managing it. I know one of the benefits on the website BMTInfonet, there is a search engine for doctors that are very well known for GVHD management with specific GVHD systems. So if you go to BMTInfonet and look for a doctor, keep in mind if you put your state in, something might not come up. So I recommend that you just put what type of GVHD doctor you're looking for, and it'll tell you who some of these top providers are in the country if you and your doctor are having a hard time managing it. There are some wonderful people out there to turn to. And then I see something here. Is it true T cells from the donor attack organs and tissues so that patients get GVHD? Any thoughts on that, Leora?
My understanding is that as patients are being tapered from steroids, and again, I'm not a physician, that the donor cells can attack the body. So how the pace of how you gradually suppress or reduce your steroids is really very individualized. So that's something to be really concerned about, is that yes, T cells from the donor cells can attack the organs, but that's where the steroids and the medications that your physician puts you on and the pace by which is really important. So keeping in contact with your oncologist is critical. But again, I'm not a physician, so I don't want to speak inappropriately.
Oh, no, I appreciate your thoughts on that, and that is something we encourage everyone to talk to their doctor. I know there's something on here about, is there a way to prevent GVHD? And like I said, there's a lot of research coming out. There's a new medication they're trying to give people to make it less likely. But GVHD, all you can do is you follow everything your doctor tells you to do, you eat your best, you take care of yourself, and what will be will be. It's not that you did something horribly wrong if you are following what your doctor is telling you. You just do your best, but there is no 100% foolproof way to avoid GVHD. Kevin, is there any way that you could remind them if anybody else has any other questions?
Absolutely. If you'd like to ask a question, please type it into the Ask a Question feature on the left side of your screen. One moment, please, while we poll for further questions. It appears there are no further questions at this time. I'll turn the floor back over to you.
All right. Well, I think we're probably going to be finishing a little early today, but I just want to thank our speakers, Sarah and Leora. What a wealth of information. Thank you so much for being here with us today and helping us to educate people on how they can best cope with their GVHD. And I thank all of you for being here on the call today. And we hope you learned something new. And if you need more support, certainly reach out to us. And Kevin, thank you so much for hosting us today.
Thank you, Jennifer, and thank you, everyone. That does conclude today's webinar and teleconference. You may disconnect your lines at this time and have a wonderful day. We thank you for your participation today.